Cauda equina syndrome, often abbreviated as CES, is a rare but critical spinal emergency. It occurs when the nerve roots at the lower end of the spinal cord are suddenly compressed, leading to rapid and potentially irreversible neurological damage. Patients typically present with back pain, but what makes CES so dangerous are its red flag symptoms, such as bladder or bowel dysfunction, numbness in the saddle area, and weakness in the legs. If not diagnosed and treated quickly, CES can result in permanent disability. This video will guide you through the latest UK recommendations, helping healthcare providers recognize, investigate, and manage CES efficiently. Back pain is one of the most frequent complaints in both primary and secondary healthcare settings. While most cases are benign, about 1% can be attributed to serious causes like CES. Recognizing when back pain is more than just a musculoskeletal issue is vital. The UK guidelines emphasize the importance of thorough clinical assessment to rule out CES, especially when patients present with new or worsening neurological symptoms. Early identification can make the difference between full recovery and lifelong complications. Cauda equina syndrome is considered a surgical emergency because the window for intervention is narrow. Once CES is suspected, UK guidelines recommend urgent MRI imaging within 4 hours and surgical decompression within 24 hours if confirmed. Delays can lead to devastating outcomes, including paralysis, incontinence, and chronic pain. The urgency is reflected in the new GIRFT pathway, which standardizes the approach to diagnosis and management, ensuring patients receive timely care. Cauda equina is a bundle of nerve roots located at the lower end of the spinal cord, between the L2 and S5 vertebrae. These nerves control sensation and movement in the legs, as well as bladder, bowel, and sexual function. The cauda equina is protected by 3 meningeal layers and bathed in cerebrospinal fluid. Damage to these nerves can result in flaccid paralysis, loss of reflexes, and altered sensation in the perineal region. Understanding this anatomy is crucial for recognizing CES and its symptoms. Magnetic resonance imaging, MRI, is the gold standard for diagnosing CES. T2-weighted MRI images reveal the structure of the spinal cord, conus medullaris, and cauda equina. These images help clinicians identify compression, disc herniation, and other abnormalities. The UK guidelines recommend standardized imaging sequences to ensure accurate diagnosis. Rapid access to MRI is essential, as it guides urgent surgical intervention and prevents irreversible damage. CES is rare, with an annual incidence of about 2.7 per 100,000 people in Scotland. It is more common in females and typically affects those around 58 years of age. While CES is uncommon in the general population, it is more prevalent among patients with back pain or those exhibiting red flag symptoms. Understanding the epidemiology helps clinicians maintain a high index of suspicion, especially in at-risk groups. CES is most often caused by acute compression of the nerve roots, usually from disc herniation at the L4, L5, or L5S1 levels. Other causes include spinal fractures, tumors, iatrogenic lesions, and lumbar stenosis. Disc herniation accounts for nearly half of CES cases. Recognizing these causes is important for targeted investigation and management, especially when patients present with back pain and neurological symptoms. Within the spinal canal, the cauda equina occupies a significant portion of the available space. Compression reduces blood supply, leading to nerve ischemia, edema, and eventually irreversible damage. The progression from nerve root crowding to compression is rapid, and once injury occurs, regeneration is limited. This underscores the need for urgent intervention to prevent permanent neurological loss. Historically, CES was classified into early, incomplete, retention, and complete stages to guide prognosis and timing of surgery. However, recent UK guidelines recommend abandoning these classifications for emergency management. Instead, the focus is on recognizing red flag symptoms and facilitating rapid MRI and surgery. Classification may still help with consent and prognosis, but should not delay urgent care. Patients with CES often present with new or worsening back pain, difficulty urinating, altered sensation in the saddle area, severe leg weakness, or sexual dysfunction. Recognizing these red flag symptoms is crucial. If any are present, immediate referral for MRI is recommended. The UK guidelines also highlight the importance of safety netting for patients whose condition may deteriorate, providing them with information on when to seek urgent help. Thorough neurological examination is essential for suspected CES. This includes testing perianal sensation, anal tone, anal squeeze, and reflexes. While positive findings only have a 30% predictive value, a single positive test should prompt emergency MRI. The examination should cover dermatomes, myotomes, and reflexes from L1 to S5. The latest evidence suggests comprehensive assessment is more reliable than relying on classification alone. Post-void bladder scanning is now recommended as a rule-in, not rule-out, investigation for CES. A residual volume over 300 ml supports the diagnosis, but scans should not be used in isolation. Many patients with confirmed CES have lower volumes. If the patient cannot void, catheterization and further testing are required. Accurate documentation and interpretation are key to avoiding misdiagnoses. Several conditions can mimic CES, including lumbosacral plexopathy, conus medullaris syndrome, Guillain-Barré syndrome, multiple sclerosis, and spinal cord infarct. Negative findings across neurological tests and bladder scans can help rule out CES. However, UK guidelines recommend a low threshold for suspicion. If red flag symptoms are present, emergency MRI is warranted to avoid missing critical cases. Definitive treatment for CES is urgent surgical decompression. The sooner surgery is performed, the better the outcomes. UK guidelines recommend decompression within 24 hours of MRI confirmation. Even patients with complete CES benefit from surgery, though prognosis is poorer. Timely intervention is critical to preserving neurological function and preventing permanent disability. Implementing the latest GIRFT guidelines requires efficient pathways, especially in hospitals without 24-hour MRI access. Local adaptations, interhospital transfers, and clinical networks help streamline care. Artificial intelligence may soon assist in triage and diagnosis, but clinician awareness and timely action remain paramount. Ongoing efforts to improve pathways and clinician education will ensure better outcomes for patients with CES.